My name's Loretta Sollers and I'm Deputy Head of Children and Young People Families Team at Public Health England. Welcome to this morning's session. Thank you for joining us for the first session. I know if you were up late last night, it's kind of difficult to leave that bed sometimes, but we've got a really inspiring group of speakers to get your brain cells working this morning and all fired up for Steve Bryan, who's the kind of follow-on act after our session. Okay, so we've heard a lot over the last couple of days about the importance of taking a complex systems approach to understanding public health systems and public health problems. We've also heard a lot over the last couple of days in terms of the importance of mental health and how that is such a major public health issue for us. We're bringing the two of those together in this morning's session and putting the spotlight on children and young people's mental health. At Public Health England, we've been looking at the issue of children and young people's mental health from a complex systems perspective for a while. So having this session this morning was a real opportunity for us to share with you the thoughts of colleagues that we've been working with, and actually, most importantly, to start with the young people themselves. I was really minded when Duncan Selby yesterday morning in his keynote presentation said, if you're not where the people are at, then forget it. And I was thinking, yeah, it's really good. This morning, we're going to start with the views of some young people in terms of how mental health affects them. And we need to do more of this. We don't do enough of it. So I'm really pleased that we've got that as a starting point. Following on from hearing what young people think, you'll hear what the evidence says. Professor Emma Fitzsimons is going to talk to you about some really fascinating things that she's uncovered from the Millennium Cohort study. And then we'll finish off actually getting grounded in what could be happening, what should be happening in good practice, because start with what the issue is from the young people as they experience it, then look at what the evidence base tells you, and then you've got to apply it ultimately into practice. It's no good stopping with just your theories and your academic interpretation. You've got to do something about it afterwards. So that's what we're going to try and capture for you this morning. And I'm going to hand over straight away to Gabby Clements and Jumi Otaiku, who are members of the steering group for the campaign that's being led by Our Minds, by the Youth Access Organisation. The campaign is Our Minds, Our Future. They're going to talk about their perspectives, and they're also supported by James Kenrick, who's the Chief Executive of Youth Access, and Cara Wayland-Larty, who's just been appointed as their Senior Policy Officer. So thank you very much. Please give them a warm welcome.
Hi, so I'm James Kenrick. I'm Chief Executive at Youth Access, as Loretta said, and I've titled our presentation Taking a Whole Person Approach to Young People's Mental Health rather than a whole systems approach, because I think it gives us a better chance of tackling the growing gap between demand and provision. Yes, we want the system to be better joined up, but I think the system is inherently dysfunctional and needs to be configured around young people's needs rather than expecting young people to fit in with it. And I strongly believe that needs to be acknowledged if we're going to make progress. So with that in mind, just to say a few words about who we are as an organisation. So we're a very small national charity based in London, and we act as the membership body for a network of about 170 what we call 170 services that we call YACS, Youth Information Advice and Counselling Services. And I'm going to be telling you a bit more about that model in a minute. So our work largely focuses, sort of spans four areas really. One is mental health. Also integrated health and well-being models for young people, young people's rights, and realising young people's power to shape services through their lived expertise. And increasingly, we're focusing on bringing all four of these elements together in our work to create the change that young people demand. So, we only exist because too often, sadly, the system fails to meet young people's needs. Services often don't exist for young people, or where they do, young people aren't aware of them, or those services are inaccessible or unresponsive to young people's needs, and they aren't joined up, or youth-focused. They're usually either for children or they're for adults. And services tend to intervene far too late. This will all be familiar to you, and I'm not going to dwell on these points. And I think it's also worth saying that these failings don't only apply to mental health services. I've actually used a very similar slide around legal advice services. You could probably apply it to other services too. And these failings have also existed for decades, which is why our services evolved in the first place, and why I suppose I have little faith in the system holding the answers. However, in 2015, Future in Mind, which, as you'll know, is the Department of Health's sort of blueprint for children and young people's mental health, identified our Y-axis model as key to breaking down these barriers. And it stated that one-stop shop services based in the community should be a key part of any universal local offer, building on the existing network of Y-axis. And it identified Y-axis as well as having a specific and crucial role to play in meeting the needs of young adults. And we've seen a fair amount of additional investment in our services actually over the past couple of years of CAMS transformation models. So what is the model? So essentially, this is it. It is a high street open access model whereby young people can often drop in without an appointment for help on a wide range of issues, from mental health and sexual health to housing, homelessness, benefits, debt, employment, relationships, drugs and alcohol. Typically, there will be a team of youth workers, advisors and therapists on hand to offer a range of services in-house, including information advice and advocacy, counselling and other psychological therapies, health clinics, so sometimes there are GPs coming into the services, or sexual health nurses, and also group work. It's not a new model. It's been around since about 1960, when the first service opened, and there are lots of them around the country, but going by different names, so they're not called Y-axis, they're not called Youth Access, they're called things like No Limits or 42nd Street in Manchester. There are lots of off-the-records around and youth inquiry services. So you may have come across one or two of them in the course of your work. And the key to their success and their accessibility is the strong relationship of trust that they can build with young people. And that trust comes from their ways of working as much as the services that they offer. And so just to sort of, rush through some of the sort of key principles of Y-axis which make them successful, which lie behind their accessibility. They're open access, so they're free at the point of delivery. They don't operate the kind of arbitrary clinical thresholds that are often found in statutory CAMS. Young people can self-refer. They're young person-centred, so they're just for young people. They're not for younger children. They're not for parents. The influence of youth work ensures that they're welcoming and informal. And they're joined up. So they're built around young people's needs, not the systems. And they provide support around mental and emotional health, social and personal issues, as I've said before, in a coordinated way. They're also flexible. So they typically have a range of access routes, from drop-ins and appointments to online counselling. And they're open up to the age of 25, which is crucial. And that avoids the problem of unsuccessful transitions that we often find with statutory services, like, so for example, with CAMS and the transition to adult mental health services. I'm going to rush through these other ones just because of lack of time. They're also empowering, helping young people make informed decisions based on an understanding of their rights and options. And they give young people a voice to influence the system through participation groups, social action and campaigning. They're committed to best practice, and they're accountable, which is crucial, to funders, to their local communities, and increasingly we're working to make our services and the wider mental health system more accountable directly to young people. as we think that may be the most effective way to drive improvements in quality and access. So, I mean, there is also a sort of strong evidence base behind our model, which, obviously the model's been around for 50 years now, so as you can imagine, there's been a reasonable amount of research done on it, although not enough. We're still trying to fill gaps in the evidence base. We recently undertook a national youth counselling study with Professor Mick Cooper, which collated data on over 2,000 young clients over a 2-year period using tools commonly found in CAMS, such as the Current View tool and CORE and for outcomes, and the CHI ESQ measure for service satisfaction. And we found that, so the data was really interesting. It found that essentially the young people coming to WIACS are different to those going to statutory mental health services. They're significantly older on average than those going to CAMS, so there's an average age of 18 as opposed to 12 in CAMS. They're more likely to be female, they're more likely to be BME, LGBT, and a range of other sort of vulnerable groups are better represented. Far from the voluntary sector doing lower level work, the data also shows that young people coming to our services actually have higher levels of psychological distress on initial presentation than those presenting in CAMS, and higher levels of complexity. And they were more likely to present with generalised anxiety disorder and depression and low mood. Clinical outcomes are very similar, actually very comparable to those in statutory CAMS, with similar recovery levels and much lower levels of reliable deterioration. And we found very high levels of client satisfaction, much higher than those found in CAMS, which was attributed by the researchers to the more person-centred approach. So essentially, the study makes, I think, a really strong case for WIACS having a really key role to play in addressing mental health inequalities and inequalities in access to mental health services. We have got lots of other evidence too about some of the other interventions, which I'm very happy to talk about another time, but I won't go into now. And perhaps more importantly than the research evidence, and maybe something that Loretta was sort of alluding to as well, young people consistently say that it's what they want, and we recently supported over 240 young people to develop a charter for person-centred mental health and wellbeing services, in which they were really clear about what they want from services. And we're now working with young people through a couple of projects to make both our members, so WIACS and statutory mental health services, more accountable to young people for the way that they deliver their services and how they uphold young people's rights to receive good quality services. And one of those projects is called Make Our Rights Reality, which is predicated on the belief that rights plus action, plus voice plus action leads to change. So we're educating young people about their rights, we're supporting them to take action in their communities, and we're amplifying their voice at a national level through rights-based campaigns. And at this point, I'm just going to play a video which we've made for the launch of a new campaign called Our Minds, Our Future, which Gabby and Jummy are going to talk to you about. So I'm just going to play this, and then they will take over and talk to you.
You and your mental health. Battling with your mental health is hard enough, but many of us are fighting with the system too. The mental health system is messy and confusing and stops many of us getting the treatment we need. So what can we do? First, we need to understand our rights. Make Our Rights Reality trains young people to know our rights and when they're not being met. We all have the right to mental health treatment, but too many of us are having the same battle to access care. If we all work together to take on the system and fight for our rights, we'll be so much more powerful. The government can help too. Right now, they're making a plan to improve the mental health system for young people. But we need to make sure they're listening to us, so they know exactly what each of us needs and what that should look like where we live. After all, it's our minds and our future. Then there are the local decision makers, the people who decide day to day how money for mental health is spent and how local services are run. If hundreds of us all over the country could get these decision makers on our side, we could take on the mental health system and build something that works for all of us. We want 3 simple things. 1, we want access to services in our communities, not miles away or only in schools, and we need help at the right time, not after months of waiting. 2, we want dedicated services for young people up to age 25, so we get age-appropriate care instead of being pushed into adult services before we're ready. 3, we want young people's services to be properly funded from both adult and children's health budgets. We're tired of not being taken seriously, and we're done waiting for our rights. Our Minds, Our Future is a campaign led by young people for young people. It's our mental health and our futures at stake, so it's us who will be taking the lead. If you want to take the campaign into your local area, you won't be alone. There are already rights advocates taking the lead in local areas all over the country, and you'll get support, training and resources to help. And together, we'll take charge of our minds, our future. Sign up as a rights advocate and share to spread the word.
Great. So that video kind of explains the Our Minds, Our Future campaign, which is the first campaign to come out of Make Our Rights Reality, the Make Our Rights Reality programme. So we know from the work that James mentioned that young people all over the country are kind of being failed by the mental health system in a lot of ways. It's not meeting their needs and it's not meeting their rights. And moreover, the issue that they articulate time and time again is that they feel cut out of the decision-making process around their care, that they feel like a problem to be fixed rather than an asset in building the solution that would actually work for them as an individual person. So Our Minds, Our Future is all about equipping young people with knowledge about their rights within the mental health system and how to call out when they're not being met. But fundamentally, it has at its absolute core ensuring that services that are designed for young people are designed by young people, because that's the only way that we're going to know that that's the service that they want. So in fitting with that ethos, rather than explain the campaign to you, which I've been working on, the guys that actually came up with this campaign are the steering group of young people from all different parts of the country. So I'm going to hand over to Gabby and Jummy to explain a little bit more about how that campaign came to life.
So, hands up if you're ready. This is just a joke that I'm starting with. Hands up if you have an allergy. Hands up if you hate cheese. So, imagine that I am a waiter and I work at a restaurant of your choice. And imagine instead of asking, I just give all the cheese haters a pizza, or the people who have an allergy, let's say a nut allergy, for example, I give you a Ferrero Rocher, and those who are vegetarian, a steak. They all sound like lovely meals, but it's not going to work for everybody. So we need to at least have a menu to give people a choice and ask and genuinely listen. Even better, let them in the kitchen. It's the same in the mental health system. Only by engaging young people and genuinely listening and handing over power that the system can meet our needs. It doesn't have to be this way. There is a solution. When decisions that are being made that affect mental health services, young people should be given a seat at the table, to have the opportunity to have a say in how decisions are made, as young people will be affected by the outcome of the decisions made. This way of working allows young people to let you know what's wrong, and by working together, we can figure out a way to fix what is wrong. Here are our first set of demands: access. We want services to be local, community-based, accessible, so they will be close to home. Young people can easily just drop into these services. This is a way how we can improve mental health services. We want services to be funded from both child and adult mental health budgets. And we want services to serve young people up to age 25, not 18. Underlying all of these demands is that young people should be given a seat at the table. The reason for this is that the demands for some young people might be different. Local areas might be different, and this is why young people should be represented at the table.
So, hi, I'm Gabby. So I am part of the steering group with Jimmy. So as Jimmy said, this is everything we've just been through. So I'm going to be talking about how we actually achieve what we've just said. So I'm quickly going to run you through the structure of the levels of the people working on this campaign. So there's the staff at Youth Access, some of whom you've met. And then on the Make Our Rights Reality team, there's then our steering group, who are for Our Minds, Our Future. So there's 10 of us, and we're a group of extremely diverse young people from a variety of backgrounds, cultures, races, sexualities, areas of the UK, and most importantly, a variety of experiences of the current mental health system. We work as an advisory panel at every level of the campaign, so that's everything from the initial strategy a year ago that we started, and right through to implementation. And we're trained in all sorts of things, but most importantly about knowing our rights specifically. So then next is our network of rights advocates. So they receive similar training to us, and their focus is on approaching and communicating with organisations like CCGs and CQCs. And this is on a local basis, so our rights advocates are all over the UK, like the video explained. But what's important is what makes this kind of participation different from other activist networks. And that's the ethos of focusing on building individual human capital and developing as a steering group and advocates, but also as campaigners individually and as young people. It's about building the campaign moving forward, but also building the future and the future campaigners and just humans. So it's about equipping us with the ability to deliver the campaign and sharing the power that it takes to do so. Just one example of this is the Rights Advocates Network itself. So it was an idea that I initially proposed to the steering group all the way back at the beginning. And we built it around experiences of myself and other panel members who had specifically had experience of kind of champion schemes or activist networks from other kind of organisations that were just not good enough. And these not so good schemes were effectively using the label of a champion, activist, advocate, however they phrased it, to take credit for individual activist work without actually building on the knowledge, power and assets of the young people that they were trying to be working with. Our rights advocates, on the other hand, are given training on their mental health rights, networking, debating, and other skills like that, to empower them and enable them to deliver the campaign locally themselves. So it suits the local needs of young people in that area, just like what our demands are. And this is the key point. If you take anything away from our talk today, it's that young people like me and Jimmy and our mental health are not a problem that needs to be fixed, but we can help build our own solutions to the issues that we're the ones facing on a daily basis. All we need to do is a seat at the table, like we said. And cool. So if you think you can help or you're interested in what we do, get in touch. That's as simple as that, really. Contact Youth Access using information here, or give us a Google. And let's build a better future with the young people that are actually living it. Thanks.
Thank you so much to all four of you. That was excellent introduction. Okay, so we're going to change tack a little bit now, and our next speaker is Professor Emma Fitzsimons, who's Professor of Economics and Director of the Millennium Cohort Study at the Centre for Longitudinal Studies at University College London. She's going to talk about the Millennium Cohort Study and what she's been finding out and we can learn about in terms of the risk and protective factors associated with mental illness and mental well-being for today's young people. Emma, thanks very much.
Great. Morning, everyone, and thanks, Loretta, for the introduction. And just to echo what you said, I thought the previous talks were fascinating and very inspirational, so thanks for that. I hope my talk will be somewhat complementary to what we've just heard. So I'll be presenting some statistics, some recent evidence on mental health and mental illness and well-being in the UK today. Just to briefly introduce what I do, so I direct the Millennium Cohort Study, which some of you may have heard of. So it's a longitudinal study which follows individuals throughout their lives, so from birth, and the intention is to follow them through the life course, so a cradle-to-grave type study. And we run 4 of these studies at the Centre for Longitudinal Studies, which is based at UCL. So the Millennium Cohort Study is the most recent of the studies we run. It's a very, very large study, so we're dealing with really, really large numbers. It follows around 19,000 children born in the UK in 2000, 2001. So they're currently around 17, 18 years old. And very importantly, it's nationally representative of the sample born in that period in the UK, which allows us to get really accurate statistics on many things, but what I'm going to talk about today is mental health and well-being in the UK today. And I'm going to break it kind of into 2 parts. I'm going to mainly focus on age 11 and age 14, the more recent statistics. We're currently in the field at age 17 and should be wrapping up in about a year's time, so we'll have statistics on age 17 in about a year. So since the age of 3, we've been measuring mental health problems amongst children and young people in the UK. We've measured that through parent reports using the Strengths and Difficulties questionnaire, which is a widely used tool used in several other studies, developed by Professor Robert Goodman several years ago. So it is parent reported, this particular aspect that I'm going to show you some statistics on, and we've measured it at ages 3, 5, 7, 11 and 14. And I'll show you some statistics on 2 of the subscales, so the emotional subscales and the conduct hyperactivity subscale. And a score above a certain threshold is indicative of high levels of difficulty in that particular area. So I'll show you the proportions that have scores above that particular level at each of those ages and how it's evolved over time. And remember, we're talking about the same people, so we're able to track within the same people how things are changing over time for them, which is a really, really unique and important feature also of the study. So this just shows you gender differences in emotional problems by age. So I think the main thing I'd like to highlight here is between the ages of 7 and 11, so the latter stages of primary school, we observe quite a stark increase in prevalence amongst both genders, both boys and girls. And then from ages 11 to 14, things have remained fairly stable for boys, but there's been a very sharp rise in the prevalence of emotional problems, as reported by parents amongst their daughters. So around 18% are reported to have high levels of emotional problems at that age. So I think that's been quite a stark major finding from the study in the past sort of 12 months. How that compares with another aspect of the STQ questionnaire, behaviour problems. And just to point out some gender differences. So here, in general, the prevalence tend to be higher amongst boys than girls. It gradually, we see it's quite high at the age of 3, the kind of toddler years, as is concurrent with many other studies and what one would expect. And then there's quite a sharp decrease to age 5, and it's remained pretty stable over time. Small increase from 7 to 11, not anywhere as noticeable as the increase in emotional problems. And throughout boys, parents are reporting higher behaviour problems amongst their sons than amongst daughters. And again, that's consistent with other studies and what they've found. I'm going to just focus for a short while on mental ill health and well-being at age 11. And I'll show you 3 infographics. What we've done is we've looked at the predictors or the factors that are associated with children's well-being at age 11. It's a very rich study. We've lots of information about the families, the parents, the home, the community, and so on. So it allows us to look in depth at what are the factors that are most associated with children's well-being at age 11. And the way we've done this, we've broken it into individual level characteristics such as gender, ethnicity, and so on, family, relationships, home life, socioeconomic circumstances, occupation of parents, income, and so on, and the wider school and environment that young people are living in. And the protective factors are shown with a white circle and the risk factors with a black circle. So for instance, school engagement is protective in this model, reporting that one likes school, whereas arguing with parents is highly predictive of lower well-being. I won't dwell on this because I just want to get on to the third slide in particular on this. This is a similar, we've looked separately at well-being and mental illness, which I think is really important to do. They're not 2 sides of the same coin. We find that children who report, low well-being don't necessarily report mental ill health and vice versa. So I think it's really important to measure both aspects amongst the same group of children. This shows you the risk and protective factors for mental illness, but what I'd like to, and the greater the circle, the more associated, the higher the correlation with mental illness. What I'd like to show you is the extent of overlap between the correlates. So actually, the section in the middle, the intersection, shows that there are some factors that do predict both mental ill health and low well-being. However, there are other factors that are predictive of one but not the other. So it's not, I think the message I do want to get across, it's not that these are 2 sides of the same coin. It's not that the same factors are predicting them in the same way. They're very different concepts, and I think really important to measure them, measure both of them, and understand what factors affect each of them. So that was age 11. At age 14, I want to just show you some high-level statistics that we've looked at in the age 14 survey. So for the very first time in the study, the young people themselves, the cohort members, reported on their own mental health using the Short Moods and Feelings questionnaire. So previously what I showed you was based on parent report. And when we look at the young person, their own report of their own mental health, which they do in private, it's a self-completion questionnaire they're filling in, we measure that almost 1 in every 4 girls at age 14 report high levels of depressive symptoms. So they're above that cutoff that is indicative of high levels of symptoms, compared with 1 in 10 boys. And we can scale those figures up because this is a nationally representative study. It is indicative of the kind of proportion we'd expect right across the UK. And these are very large numbers. That equates to around 67,000 boys and 166,000 girls nationally, if you scale those figures up. So I think that really highlights the scale and extent of the issue. Those findings attracted quite a few headlines that some of you may be familiar with, in May. A really nice feature is that we can compare how parents report with how the young people themselves are reporting at age 14, because we have parent reports via the Strengths and Difficulties questionnaire on their own children, and we've the young persons report themselves. And that's the first time we can do that. It's striking how low the correlation is in terms of how they're reporting. So it's lower than 0.3, 0.27. So very, very low correlation between what parents report and what the young person themselves report. And again, I think that's just an important message that I wanted to show on this slide. And in particular, parents are tending to over-report mental health problems amongst their sons and tending to under-report amongst their females, their daughters. So around 18% of parents reported high emotional problems. We saw that earlier on amongst daughters, and when you measure it amongst the young people themselves, it's around 25%. And also it's very different, daughters who are reporting that. The correlation is very low. And just briefly on well-being at age 14, like the mental ill health, we also see stark sex differences. Girls are much more likely to report lower well-being than boys. So for instance, if we categorize well-being into thirds, it's a continuous measure. So if we just break it into thirds, high, medium and low, we see that the lowest thirds has around 62% girls compared to 38% boys, and the highest third has around 43% girls, 57% boys. So again, it's just, I think, highlighting the stark gender difference we observe also in well-being at age 14. And finally, what I've said already, just to emphasize, mental ill health and poor well-being don't always go hand in hand. So a large proportion of young people experience low well-being despite not having high depressive symptoms. And I think it's important not to overlook that and miss that side of the story. So as I said, we're in the field now at age 17, and I think the spotlight's really going to be on how things have evolved for these young people from age 14 to 17, which we'll know in about a year's time. So I heard my bell there, so I shall stop. So thanks very much.
So as a parent of a 16-year-old boy, when I heard that finding that I've absolutely no idea what my son's state of mind did, it really made me kind of like grip onto things. And I thought, actually, it's my husband. He doesn't know what it is. I know, really. But anyway, last speaker is Anne Berry, who is a Public Health Commissioning Manager at Nottinghamshire County Council. Anne's going to share with us some local practice that is taking a trauma-informed approach to young people's mental health and the impact that this is having locally. So, Anne, over to you.
So I'm a public health and commissioning manager, and I work as part of a team of integrated commissioning for children's services across Nottinghamshire. So we work on behalf of CCGs as well as Nottinghamshire County Council Public Health Services. I've explored the leading global ACEs, that's Adverse Childhood Experiences, Science and Evidence. And I've come to see that adversity in childhood impacts on health through the life course. And furthermore, I ask whether it's part of the root causes for health inequalities. We'll look at ACEs initially and the impact and the science behind it, and then what to do in public health when commissioning. So here is the World Health Organization's definition of adverse childhood experiences. And health behaviour in school-aged children, European region includes all countries of the UK and supports efforts to routinely ask about adversity in childhood and supports interventions and prevention. And what I mean by that is routinely asking about adversity in childhood in a supportive way that enables disclosure in order that we can deal with this early and it doesn't take the time to become complex as the child grows and develops relationships and makes choices in life. And that's part of every child's right to be heard for the United Nations Rights of the Child. Here are the most commonly cited and researched ACEs that we know most about. And these come from a study from Vincent Folletti in the USA. Childhood here is defined as 0 to 18 years. And you'll see the first ones are the ones that come to mind when you think about adversity in childhood. From divorce down, we are looking at the disadvantage that children have when their parents are absent for one reason or another. And what I mean by that is not emotionally available to them. And that has a high impact on their mental health and well-being. A little bit more. Oh, I'll try again. That's it. When we look at adversity in childhood and trauma and toxic stress and vulnerability, these are all terms that you will see emerging now as you read documents on this sort of work. Vulnerability is a term that we use in England, but it's actually not quite as popular as some of the other terms because vulnerability implies that it's somehow your fault. And clearly, adversity in childhood has nothing to do with the child at all, and everything to do with the people that are looking after them and the environments that they're growing up in. So we know that counting ACEs will indicate the level of toxic stress and trauma that children have experienced. We know from this study that 4 or more ACEs in childhood will lead to biological, psychological, emotional and social problems throughout the life course. They're twice as likely to binge drink, 5 times likely to use illicit drugs, and 46 times likely to be IV drug users. That's 4,600%. 11 times more likely heroin, crack, or being incarcerated. 7 times more likely to be involved in violence, either as a perpetrator or a victim. And the manner of death between 12 and 35 more likely risk of suicide. So some of these data are from the study from 1998, and some of them are more recent and not yet published from Folletti's latest research, due to be published any time this year now. And the 2 significant differences are the 46 times IV drug users and the 35 times increase of suicide. And I think this is really important to note. These studies have been going on since 1998. It's longitudinal and it's huge numbers. They come from white middle-class Americans paying for health insurance. So moving quickly on now. There are 5 ACEs sciences, and it will help us to determine what to do to prevent them. I'm going to move swiftly because 10 minutes feels like a lot less standing up here. And I'm going to move straight to the policy. We have 2 policy and guidance documents, Future in Mind and Transforming Children and Young People's Mental Health Care Provision in the Green Paper. So when looking at commissioning in services to promote and support emotional mental health and well-being in young people, that's prevention and early intervention. I looked at that through the ACEs lens when I came to commissioning. Future in Mind, Chapter 4, talks about resilience building. And the Green Paper talks about supporting and providing early intervention, preventing escalation, and referral into CAMS in schools and colleges. This is the commissioning cycle that I followed, and you'll recognise that this is a systematic approach to give us the wisdom to act so that we make the right commissioning decisions. And when I was commissioning, I was looking at the outcomes. We were looking at young people's personal development and a whole school approach to that. If you do what you've always done, you'll get what you always got. That's what Albert Einstein says. So this is an opportunity for me to try and do something different. And I'm also aware that the field of prevention in emotional mental health and well-being in children is quite barren, so that this is early determinants, and we are evaluating it as we go along. So we've got 2 programs, resilience building in schools, and we have a company called Each Amazing Breath, taking a yoga sort of approach to it, grounding children and helping them to breathe and change their brain chemistry and their behaviour. And we also have Young Minds, who've got an academic resilience approach, and that is about holding a child in mind. From many research papers, we know that having one significant person, at least one significant person in your life, will make a difference to your emotional mental health and well-being. You have to have someone rooting for you. Otherwise, you are absolutely walking your life path alone, and that is not good for your mental health. On the horizon now, we're looking at routine inquiry into disclosure of adversity in childhood so that we can support and prevent that from escalating. The resilience building was jointly funded with Public Health and CCGs, as I mentioned earlier, through the Integrated Commissioning Hub, and we have got 2 providers in doing evaluation. This is some very, very early data. This is the process that we followed, and these are some of the outcomes at the moment from that. When we asked people to describe in one word how their experience of these services were, and it's interesting that children predictably, it's boring, yeah, but actually quite a lot of other very good words being used that are very similar to what staff are saying. Okay, this is a model that I've put together around how we should address this, where we're looking at a top-down approach to inquiry and supporting that, and a bottom-up approach to building resilience. I've also developed some emotional mental health and pathways with no funding available, and using the goodwill of staff and colleagues in schools across Nottinghamshire, schools and colleges. So we now have emotional mental health and wellbeing pathways for primary, secondary and colleges. And interestingly, after some discussion, it was agreed that we would look at behaviour as an integral part of that, rather than a type of issue that has to be dealt with separately in schools altogether. So a real understanding that behaviour is a symptom of underlying causes, and that's a huge breakthrough, and that has now been launched. We employed something called a hug, a huge, unbelievably great goal. I did this because a linear action plan just wasn't possible. There just isn't enough people on the ground to actually work on this in a steady way. But that was done in consultation with schools. So I think I've covered the what and the why and the how and who needs to be involved with this. I've used world-leading science and evidence, and I've made an economic case for prevention. It costs £4,000 per primary school and £8,000 for a secondary school to put this in place. And I believe that we're working towards a healthier and fairer society as a result. Thank you.
Thanks ever so much, Anne. I'm going to ask all of our speakers now to join us on the chairs at the front, and we've probably just got time for one round of questions. So as you're figuring out what question you're burning you'd like to ask, I think the 2 points came to mind as Anne was delivering her presentation. The first one was that if you're a commissioner of mental health services or mental well-being, absolutely take a look at those slides that Anne has shown up there. There's a lot of information on them, really worthwhile stuff, real practical stuff for people to take account of. And the second thing was you mentioned that the evidence was pretty barren in terms of prevention and resilience building. Public Health England has been given the remit to establish a special interest group. It's one of the tasks of the Green Paper on children and young people's mental health. And that special interest group is doing just that. It's looking at what is the evidence base for building a preventative approach around children and young people's mental health and well-being. And we're commissioning that work at the moment, and we will report by the end of the financial year. And that report will be very much taking account of young people's views, as you've heard this morning, looking at what is the evidence base, taking a complex systems approach, and fundamentally, we want to give some real practical guidance for commissioners that are out there working in the field as well. So it won't just be an academic output, it'll be something that will be really usable for you. Okay, so we've got the panel up here sitting waiting for your questions. Do we have any questions that we can guide the microphone to? Yep, there's one to that.
Hi, thank you. I have a question. My name is Jackie Sturt from King's College London. I have a question for Emla about your data. What we're seeing with your data, I think, is it's kind of like a snapshot in time. We know what the mental health of those 19,000 young people is when the data was collected, 4 years ago, or whatever. Do we have anything to compare that with? Do we know for sure that youth mental health and well-being is getting worse? Or is it there've never been studies anywhere near as complex as this before, so we don't know what the past was like?
Okay. Emma, would you like to use a microphone? Yep. It should be on, just
think
speak
so.
into it.
Yeah,
Yep.
okay. So there's one study, it's difficult. There aren't many comparative studies out there, but the one that I think is most comparable is one that's run in Bristol called ALSPAC. So it's a large study, but it has a regional focus. It's not nationally representative. And the cohort members are around 10 years older. So if we look at their measures at around the same age, 10 years ago at age 14, amongst girls, for instance, they were quite a bit lower. So using a similar scale, the SDQ, the prevalence was around 14% amongst 14-year-olds 10 years ago. And now using the short moods and feelings questionnaire rather, now it's around 24%. So there are lots of caveats around that comparison, but I think that's the closest that we have comparing 10 years apart. That is a regional sample, that's the main caveat really, but it is a large sample, so it's a pretty accurate statistic from that study. So other studies, it's very hard to find comparable data in the UK in particular. And use the older studies that I showed you on the first slide, so the cohort born in the 50s and the 70s, again, the prevalences are much lower, but again, that's sort of going way back in time, and the measures used are quite different as well. So yeah, I think.
Okay, thank you. We've got another question in the middle bank up there. I'll take that question.
Hi, just really encouraging to see the young people here today, and great you've sort of made the opportunity, got the opportunity to talk today. I just wondered, with the Care Quality Commission, when they're going to hospitals, they've recognised that patient voices are really important, and they have a patient kind of representative goes in on every kind of visit to recognise that sort of importance of the customer and the people who are actually involved. And I just wondered, as well as today, what other opportunities are there in the pipeline, do you think, to get yourselves around the table with decision makers when some of those key decisions are taking place? Is there any other opportunities you've been provided with, and is there any particular things you're looking in terms of opportunities to be able to get to influence and take part in that, as you were sort of describing, and make your demands heard?
Okay, thanks. We're just looking to see who's going to answer that question. Yep.
So at the moment we've trialled this programme. It's only really in it like halfway through its second year. So the steering group is just kind of coming to the end of their first year, and what we've tried to do is make sure that they have regular opportunities to engage in policy processes where we can. So things like coming along to this, being part of that bigger kind of policy discussion, and that's the kind of voice element of Make Our Rights Reality. And then there's the more localised, the Rights Advocates programme, which is about that local decision making. And I think moving forward, we will try to structure that a little bit more, so making sure that those opportunities are mapped out throughout the year, so that there's more opportunities to kind of engage and prep young people to partake in a really meaningful way. Which other things have you guys been to this year? Oh, NHS Expo last week. There's a NHS 10-year the 10-year plan strategy meeting next week, which I think Jenny is going along to maybe. They're doing the Maudsley debate, which is that the thing? So there's a big debating day at King's College. I think it is the Maudsley debates all around mental health. So we're trying to provide lots of opportunities for them to engage in a meaningful way that fits around their own schedules as well, which is also the difficult thing.
Okay.
Sorry, there's not many mics going
Okay, so James is just going to add something as well.
Yeah, I just wanted to say something about the sort of local opportunities as well, because it kind of feels like, I mean, actually at national level, it's easier to provide young people with opportunities to engage in national policy making at the moment than it is around some of the local decision making, which I think is, you know, which is of course is really crucial, because that's where a lot of the funding decisions are being made. So obviously that's what the campaign is intended to do, is to give is to make sure young people can get their seat at the table locally. But I think there is a bit of a disconnect between some quite progressive thinking amongst some of the policymakers actually within NHS England, Public Health England, you know, and some of that local commissioning. So I think some of the participation work that we've seen in the development of local transformation plans, for example, has you know, left a lot to be desired in a lot of areas. So I think there is a really big challenge there to develop how that those local opportunities for engagement are sort of developed.
Okay, thanks. Just the one thing I'd add to that, you did mention CQC. They did publish a report on CAM services last year, which very much went and spoke to, listened to young people who inputted into that report. And I think they're due to publish a follow-up report as well, so it might be worth having a look at that as well. Okay, we've got a gentleman over here with his hand up with a microphone, and we're just going to take that as one last question because I'm getting the time out from the conference staff here. Go ahead.
Hi, I'm Liam Hughes. I'm LGA's associate, and my question really is about the value of having a hub or contact point or services that are outside schools and outside further education.